Biomed Central Musculoskeletal Disorders Journal, which is open access online, and it's regarding the treatment of delayed union in tibias through the use of low-intensity ultrasound. When Fong offered this as a talk, I must admit I was interested, because I wanted to see how much information there was on ultrasound and whether it was effective. I must admit it was something that I hadn't really had a lot of experience with or really heard a lot about. So as far as the background for this, it's a safe and non-invasive option as far as treatment for fractures is concerned. In '94 and also in '97 there were some, use the term landmark papers or milestone papers that suggested the use of ultrasound in acute fractures. This paper in particular is talking about the use of it in delayed unions. And certainly some of the time frames of the fractures that were in this paper were almost what I would classify as a non-union. So incidence I should say, of delayed unions is in the order of 5 to 10% of all fractures. And what ultrasound is purported to offer is to actually accelerate fracture healing by a complex series of mechanisms, but they don't actually, it's not actually fully elucidated. There's actually a number of papers. There's one in 2001 from the JBGS talking about cytosolic calcium induced into osteoblasts from ultrasound. There's increase in bone formation, increased osteothickness produced from ultrasound. So, and also this concept of bone volume at the new callus. So, as a non-invasive option, I guess it's a reasonable thing to consider. The question is, I guess, cost for the unit to do it, and also patient compliance, because it relies on 20 minutes a day for 16 weeks of therapy, and whether patients be compliant with that and who foots the cost of each unit for these patients. I guess it would be similar to that of vac dressing. This is a review in the Journal of Orthopaedic Trauma in 2010, around the same time that this paper was actually published, and talking about low-intensity pulsed ultrasound as a relatively new technique, despite it actually being around for at least 16 years from those previous studies. I guess in the grand scheme of medicine, it's not new. It's not old. And this is what's considered to be low impulse, 1.5 megahertz at burst widths of 200 picoseconds. And as I said, there were larger trials suggesting it in least acute fractures. And they suggested healing rates were improved somewhere in the order of 24 to 42% for fresh fractures. Although there's been other studies that have suggested it hasn't really yielded any benefit. And so essentially this study stems from all that background research on acute fractures to try and come up with a randomised trial in non-unions. After accepting Fong's email of doing this, I must admit I was a bit perplexed by the degree of statistics in this and the use of it. And maybe I think it might be over-statistised, but if that's a word. But whether or not people agree, or it's just my ignorance of statistics, although I have done the compulsory clear courses that statistics would want us to do at the Surgery College. So the null hypothesis for this is that there's no difference. That's the actual true null hypothesis. Their hypothesis was that lupus is actually beneficial and actually promotes bone healing and increases bone density and decreases the gap at a fracture site. Now, I also searched JBGS and some of the online papers for this surrogate marker of bone healing, of bone mineral density at a fracture site. And it was quite scant, the literature. I don't know if I was searching in wrong places or not, but this paper actually references a paper from '94 which was looking at vertebral unions from bone grafting and talking about the use of CT as a place for measuring bone mineral density. But I must admit it's not something I frequently come across as a measure of fracture union or fracture healing. But they use CT scans as their final marker to determine whether bone mineral density had improved. And the secondary marker was that of the residual gap size. So this was a trial that was done over a number of centres, 6 hospitals in Germany, and they looked at delayed union, which they defined as lack of clinical and radiological evidence of union continuity or bone reaction for no less than 16 weeks from the time of injury or the most recent intervention. So I had 101 patients that fit this criteria, and as I say, some of them fitted the category of non-union. Despite their inclusion criteria being adults, they included patients from 14 years of age and evenly distributed between their groups. This concept of a sham control trial for the registrars and who aren't aware of it, there's sham operations where a patient's at least anaesthetised and given an anaesthetic, and ports are made or incision is made with no further intervention to mimic that of a true operation. So they have what's called a sham operation. Fortunately, with this device being ultrasound, they don't need to actually have any incisions or any sham incisions with no benefit, which at least is in keeping with the medical principle of prima non nocere, which is first do no harm. So at least I guess for a sham trial, this is actually acceptable. And as I said, 20 minutes for 16 weeks. Questions about patient compliance with that. And each of the devices recorded. And for this trial, they actually reported 90% compliance with that protocol. They allocated the patients on a one-to-one basis and blocked of 6, and they were stratified within each clinical site. And they used a computer-generated randomisation process for that. And as I said, they assessed bone mineral density both at the fracture site, but also 2 to 3 millimetres both proximal and distal to the fracture site, and they compared them to the healthy reference areas. And then they did this in triplicate, essentially taking the knees for their assessment. And as I said, their base endpoint was a change in the bone mineral density in pre-treatment to that at the 16-week mark. And I must admit, this is their statistics, and there's only a sampling of the statistics of what they actually used. They also used ANOVA and log regression, which I must admit, as I say, I start to get a bit bogged down in. They had dropout rates in the sham group of 24% and in the treatment group of 9.8%. And they analysed this on an intention to treat basis. And they also had a number of missing data points which they did imputation for and then continued to do their further assessment. But prior to doing their overall assessment as far as assessing gap area, they first did a priori the assessment of their bone mineral density. These are the demographics of the groups, which on the whole are comparable, apart from I think the body mass index was quite significant in favour of the control group as opposed to the lipase group. But as you can see, there was certain inclusion of those patients that had been operated on a number of times previously via various means of fixation, both internal and external. And I think that itself muddies the waters as far as risks for infection and established infective non-union. They certainly had exclusion criteria, including those of a deep wound infection during the 16-week period. But I think from clinical practice, it's evident that some of these don't become overt or floridly infected at that early stage. So I think open fractures and surgical intervention certainly can muddy the water in a variable that doesn't necessarily get accounted for well in this study. As I said, they assessed the bone mineral density at the fracture site and also within the 2 or 3 mils distal and proximal with the use of CT. And the way they did that was to actually use Hansfold units, which is a CT measuring unit for assessing densities when you do a CT. With differences in fluid and solids, and certainly within bone. So they're using CT and measuring incremental changes on a CT. You can get that with any of the Synapse packages, or you can look at what the units actually are for every part of a scan, and compared those. And they used a logarithmic analysis of that, and they made a statement in this that didn't matter whether you did it directly or via a logarithmic method, but they chose to do it via a logarithmic method for simple analysis. So in their data, both for the bone mineral density and also the gap size, they concluded there was statistical significance. As I said, this was just a sampling of the results. They did this in multiple combinations and permutations, which I haven't put up here. Which I think is just sort of shows how clever ways to play with statistics to make your argument sound good. I must not even get anything more from all the discussions of imputations and analysis that they spoke of. And if anyone did, please feel free to enlighten me, because I sort of got bogged down in all of that. This is their logarithmic graph, the Helmslab units. And they demonstrated that there was an incremental change, but interestingly, even those that weren't weren't treated showed an increase in their baseline, despite being an established delayed union, in some cases a non-union. The conclusion that they came to in this study was that it accelerated bone healing, particularly in the setting of delayed fractures, and they then took it further to say that it improves the odds of achieving a solid union, which I found was a bit of a leap again. My criticism for this paper was that I think it was statistical manipulation, making things favourable at the endpoint that they have a desired outcome for. One of the authors is actually a consultant that's actually employed by Smith & Nephew, who are the sponsors for this trial. So I think there's a bias, inherent bias that's built into it, and he was actually interpreting the data. I'm not sure of the relevance of the bone mineral density as a surrogate endpoint for fracture healing. Again, I'd be interested to see people's thoughts on that. Throughout the paper, they said, here is our finally some level 1 evidence to support this, and I think at best this paper represents a level 2 data. And there's certainly no clinical correlation. It was all either X-ray or CT-based assessment. So it's my interpretation.
Thank you, Nathan.